Well, good afternoon, everybody. Happy Friday. You've joined us for the CAF COVID Weekly Roundup. And today we're going to be covering really mainly one really large AFL, but we'll refer to a couple other AFLs that came out this week. Today is October 30th, 2020, if you didn't know. Tomorrow's Halloween. I promise no tricks in this one. No, I'm just kidding. They're all treats on this webinar. So today with us, I've got both Deanne and Patty from CAF are joining us. Deanne's the Director of Clinical Affairs and Patty is the Director of Regulatory Affairs. We're going to kind of tag team this AFL because there's a bunch of stuff in it. I'm going to go over most of the elements within the visitor AFL, so we should be able to draw a difference between the CMS QSO, so you can see that. And Patty and Deanne and I all have some, ideas of workarounds, and we have a section of FAQs as we get to the end of the presentation that we have seen have been asked regarding visitation in the other calls, both the CDPH call and the HSAG call, that we were not able to get to, or we didn't expand upon those answers enough. And we'll get to those towards the end. This is going to be this is really dry material, guys, so I apologize. Please bear with us. We will I don't know about Deanne and Patty, but I'm happy to go over if we can't get to it all, but we're going to try to give you a deep dive into this visitor AFL. So all right, before we get started, let's just recap what the normal intent of these webinars is to give you a situation report, go over the regulatory requirements that have changed during the week, talk about forecasting and best practices where we can identify those. There may be some instances, especially as I talk about the visitation, where I may say my personal opinion, and please, I will try to say that that's not a CAF official position. These webinars are brought to you through a grant-funded program with the Department of Public Health, as well as Los Angeles County and Sacramento County. And I have no financial conflicts, and neither do the other speakers today. All right, so the first AFL that was updated came out roughly a couple hours after we finished our last webinar last Friday night. And many of you guys have seen this, and hopefully you've had a chance to listen to the HSAG webinar and the CDPH webinar. We're going to go quite a bit further than we did on those two calls, and we'll dive into that in a second. But even though this AFL is called Guidance for Limiting the Transmission of COVID-19 in Long-Term Care Facilities, this is actually where we're going to refer to for all the visitor guidance. And the guidance on visitors is contained under AFL 20-38.5, but that is geared towards acute hospitals. And the only reason why I mention that is, one, I know this has caused me confusion to go look and try to refer to things, and I'm looking for information on visitors, and I obviously would go to the visitor guidance, and that's not for us. That's designed for a hospital, and as you read through that AFL, it's pretty clear that it refers to hospitals. But it does have a great link, and that's the Safer Economy, or the blueprint for California, which shows the testing and for your individual county, the positivity rates. And so as we go through this and we talk about how the visitors are limited based on the color code criteria in the state, on that state website, this is a link directly to infographic where you can see at a glance what your individual county is doing. So and we'll talk about how often you should, I know that's a big question, we'll talk about how often you should be checking that. All right, so the way I set this, kind of have set up the program, is so that we talk about the infection prevention guidance that's contained within the AFL first, because no matter what you do, whether it's inside visitation or outside visitation, whether it's dealing with other folks that are coming into the building, whether it's surveyors or ombudsmen or all of those things, we're all going to have to follow these core principles. And so we wanted to cover those first because these are the things that every one of us is going to have to follow, regardless of how we operationalize the guidance. So the reason why I say core principles plus is because if you looked at the CMS QSO, it has a defined, very small list of core principles that are very similar to what we've already done. This kind of expands upon those core principles, as well as giving kind of detailed information as to how you would accomplish some of these. So the very first one is ensuring screening of all the people that come into the building. That's a pretty easy one. It's one we're familiar with, and we're doing all of that now. What you may or may not be doing, and I could see some folks saying, well, this is we could be collecting HIPAA related information, but we need to be documenting the name and contact information no matter what, according to this AFL. And the reason for that is they want to be able to do contact tracing if that person develops symptoms in the 14 days after they have come into the facility. So it's important to have a name and a phone number or some way to get a hold of that person that has been in the facility. All visitors and residents must have facial coverings, and for the visitors and residents, they allow cloth masks or surgical face masks. I'll say if you have an abundance of surgical face masks and you could offer those to your visitors, that would be a great service that you could give to folks. And that way you can make sure that there's some kind of consistency with the source control that's being used. There are differences in efficacy on cloth masks, and you wouldn't be able to see that necessarily by just looking at it. So if you want a consistently good mask, or the best that we can offer, is that would be the surgical mask. Staff should monitor to encourage physical distancing, and gosh, we know that's going to be that's going to cause some issues, and we want to encourage folks. Well, I'll just say I know that people are going to be. It's going to be really difficult for people to follow the last part of this. The no hugging and no handshaking and no touching is going to be really difficult for our families. So we're going to have to explain to them, kind of what the expectation is before they arrive. And many of you guys have started on that process. That's great. But if you've not, expect to get some flack. Now, I think the vast majority of people are very happy that you're being insistent on them following the infection control guidelines to make sure their family members safe. But you're going to have folks, and we've already heard stories of really difficult family members who think it's an attack on their personal liberty to be forced to wear a mask or to not be allowed to touch their loved ones. So in those instances, we've got some suggestions, and we'll approach those in the FAQs at the end, but just be prepared to deal with that. And when we say monitor, that doesn't mean like a 1-to-1 ratio, like one staff to watch this. It would be more of a kind of a having an overarching view, or being able to see that the infection control guidelines are being followed. The AFL is not specific as to how many people could be assigned to somebody that would monitor that. That's going to be an individual facility decision based on just a bunch of different factors, and we're going to cover all those. If possible, you want to try to make, if you're going to do indoor visitation, you want to make the location where you're going to do a visitation somewhere near the entrance if possible, to prevent folks from transmitting or walking through the facility in areas that they don't need to be in. And no matter what, even if you don't have an area near the entrance, the location inside and outside, wherever it is, it needs to be sanitized after every visit. It needs to be well ventilated to the ability possible. You need to disinfect that afterwards. So after each visitation, you're going to have somebody in there. And even though the document does not refer to air changes, so I don't suspect surveyors are going to be asking about air changes necessarily, but it's something you might want to consider if you have HEPA filtration or something like that, that can reduce the amount of time that it takes the air to filter through that room and to be reoccupied. And that's more of a best practice. It's not a requirement within the AFL, but certainly that's something that you guys can think about to reduce the amount of time it takes to disinfect that space before you reoccupy it with either a break room or another family visit or whatever. And then you can consider the use of physical barriers. They're not 100% effective for sure, but they do help. We just want to make sure that if you're installing physical barriers, you can't compromise any of the fire life safety systems within the building. And so that means don't block a fire sprinkler, don't block a path of egress to get out, exit out of the building or exit out of a room. The plexiglass dividers are obviously clear. If you're going to do curtains, I would say, as long as you can maintain sight, that's okay. But if they're curtains and you can't maintain sight, make sure that they're clear so that you can see what's going on the inside. Was there anything there from an infection preventionist, Patty? Anything there you think would necessarily cause an issue with a facility to be able to, or do you see anything in there that maybe is missed in the guidance that folks should be considering?
No, Jason, this is Patty. No, I don't. I just know how when they're watching, when CDPH or states into the facility, just be aware that they're going to be looking how your staff is observing and monitoring these visitations. And then
I think your phone cut off, Patty. I'm going to jump to the next slide.
That we'll see.
I think Patty's phone is cutting in and out. I apologize, guys. Here, I'm going to jump to the next slide.
Jason, can you hear me?
Oh, I can hear you now. Great, thanks.
I'm so sorry about that. I was just saying, I anticipate we'll see a lot of deficiencies wrote. Just watch how you have your staff watching and observing for the infection control practices, and that you do a lot of observations and make sure you're watching to see how the staff are handling that infection control process with the observations.
And that's a great point, Patty, because as I read through this, there are so many small elements, and I've tried to capture them all. But all of these things, every one of these bullet points on all of the slides would be an opportunity for something to be wrong. And I can see survey deficiencies being written on each one of these bullet points. So that's why I want to get out the highlights to you guys. So that the second kind of core principle in their infection prevention guidance is to advise visitors and others to monitor for signs and symptoms 14 days after the visit. And obviously, if they develop symptoms, you need to advise them to self-isolate and contact their healthcare provider. The AFL goes on to state that any visitor or other person that has come into the building that tests positive must immediately notify you. And notice I put in quotation marks that must immediately notify you, because I'm not, we can't really require somebody that, that's a visitor to immediately notify us. But I think the messaging really when you talk to family members is, hey, when you leave, monitor yourself for symptoms. If you develop symptoms and you go get a test and it becomes positive, please let us know as soon as possible, because time is of the essence to be able to contact trace and figure out where the exposure might have been, and then get those folks tested to see if they had obtained the virus through that method. So even though the must immediately makes me cringe when I see that, I think we can accomplish that. I just don't know if it's realistic to expect people to you're going to be the first call they make after they test positive. But let's hope so. And you just want to have that conversation. Look, do you test positive? Please let us know as soon as possible. when we talk about contact tracing, what CDPH wants you to do and what the expectation within the AFL is, if you get that notification that somebody's tested positive, you're going to want to find out who did they visit, what staff were involved and were in that unit where the visitor had been, where in the facility that person has gone. We're going to screen any of those contacts for symptoms right away, and then work with your local health department on actions. And this is the important part, because this is highly different in different counties, and some counties have a much more conservative approach to who they consider exposed, and other counties have a much more relaxed view of folks that they have exposed. I will say the CDC has changed their definition just recently as to what is considered an exposed person, but it's up to you to find out, to make sure that your local health department does not consider these folks exposed, and then force you go into response testing and all that stuff. So not every county is the same on this, and you're going to have to find out what your individual county is, and sadly that changes somewhat frequently. So my hope is we're getting towards the end of this kind of figuring things out, but just be aware that you have to incorporate that local health department in terms of what to do on actions to take if you have somebody that tests positive that has visited your facility. The third bullet point that they talk about in the infection prevention guidance is to ensure residents and visitors and staff perform hand hygiene. This is gosh, it's already what we're doing. ABHR, or alcohol-based hand rub, is what is preferred. If you don't have enough, or you can't source any, obviously soap and water. I just want to throw this in there. If you have felt the need to hoard or source tons of alcohol-based hand rub, just know that that stuff is flammable. If you have more than 10 gallons, you need to have it in a fireproof container. So 10 gallons per smoke compartment. So I know folks has got cases and cases of that stuff, and they're going, oh, I got to keep that in a fireproof container. So it's just for an FYI for you guys. Number 4, signage throughout the facility. And from the pictures I've seen, most folks already have all this signage up and everything like that. The only thing you would want to, kind of add to that, I think from a signage perspective, is wayfinding. If you have indoor visitation that is not like right next to an entrance or something like that, where you have to direct people to a spot and you're not going to physically walk them to that spot, then those wayfinding signage, like this way to the exit or this way to the visitor area, things like that, you're probably not already doing that. So I would add that to the existing signage you already have. But if you have signage throughout the facility with proper education on COVID-19 signs and symptoms, infection control precautions, how to don and doff PPE, that is what they're looking for, that kind of signage. The 5th one here on the list is trips away. The resident must wear a cloth face covering or a surgical face mask. So think about folks that go out for dialysis. What happens to that face mask after they leave the facility, we don't know, but when we send them, we're going to send them with a mask on if they can tolerate it. All right, so we'll jump to number 6. Clean and disinfect frequently touched surfaces in the facility often. This is a no-brainer. We're already doing this. Number 7 is all staff must wear a minimum of a surgical mask and face shield when they are interacting with residents. And even though they don't say, and that's clear, it just says residents, it does not say visitors. I would think it'd probably be a good practice or a best practice to have that, especially if you're doing extended use on your face shields or your eye protection. Definitely have them on when you're dealing with the visitors as well. 8, the 8th bullet point is to continue testing per your testing plan. So, I'm not going to talk about, the above 10% in that. But as long as you're following your testing plan according to that AFL, you're good to go with the visitor guidance. Number 9 in the recommendations is consider testing if feasible, testing for visitors. The main point to see here or to talk about here is that even if, let's say it's something you do, you want to operationalize a point of care device and you use that on your visitor, and just because that person has tested negative does not mean they get to remove their mask and start hugging their loved one. That's not the way it works. It just is an extra layer of precaution for you guys. Obviously, a positive test, you're going to have the person go to their healthcare provider and probably get a confirmation PCR test to confirm. But either way, if you test them and they test negative, it doesn't mean remove masks, and all of the other infection control guidance or infection prevention guidance needs to be followed. 10, dedicated space for cohorting and a plan to manage new admissions. This should be something everybody has already done and has a plan for. The 11th bullet point in here is the one that really is a big change from what most of us have been doing up to this point. So 11 talks about communal activities and dining while adhering to the core principles. So all of those things that we talked about, screening, symptom checks, all of that stuff is in addition to this. So on those, on the communal activities, residents who are not on isolation or quarantine may eat in the same room with social distancing. So when we think about how we're going to set up our dining room, we want to limit the number of people at the table, and you can't be within 6 feet of each other. I don't know if you guys have gone to a restaurant lately, but a lot of them have kind of modified indoor seating. And if you can look at that as a visual representation of how to set up something, 6 feet apart while still having, kind of a dining experience or whatever, I think it's possible to do that. It's just you're going to have to think about doing things in shifts or to rotating groups of people. We'll talk in a second about kind of grouping folks together, but I think if you were looking for a visual of what this looks like, I think those would be a good indication of kind of how you can set those things up. Consider additional limitations based on status of COVID-19 infections. Now, how there are some modification or allowances here if you're having an outbreak in a facility to continue to have these. But I would say, if you had 5 people all of a sudden spike symptoms, and you're implementing response-driven testing, I would say now is not a good time to have communal activities until you get a handle on the extent of the outbreak. So that's why they say there could be limitations based on the status of COVID-19 infections within the building. You want to group residents that consistently participate in communal dining together. And some of the folks that I've talked to, even people that have had outbreaks, have been able to manage some of these outbreaks by really having this kind of compartmentalized group of activities for folks in the green zone together, so that even in one case I know of, an outbreak happened in their green zone, everybody's fully wearing PPE, but because they limited each kind of segment of their residents with the dedicated staff and things like that, when they did have their outbreak, it was limited to just those people in that within that kind of cohort within a cohort. And so I think if you can divide that up and do it more of in a compartmentalized manner where the staff and the residents and everybody is kind of in one bucket, even if it's dividing it up within a cohort zone, it will reduce or maybe even limit any outbreak that could occur after this. So that's kind of the thinking behind why you would want to group residents together, even within a cohort, and limit their participation communally within that group. And then obviously we know facial covering should be worn when going to the dining area, and whenever not eating or drinking. If you're drinking or eating, that's not going to work. And then group activities may be also facilitated, but the preference is going to be to try to find outside areas because of the ventilation factor and being able to have good airflow outside versus inside. So now, Deanne and Patty, this is the part that really scares me, and I think about this. Are there any other additional considerations of how you think you should group folks together operationally in terms of minimizing the risk from these communal activities?
Jason, this is Deanne. I'll jump in. I don't know if there's any additional way that you can group them. I mean, it's really going to take the facility effort to coordinate and maintain those groups within a group. So if you have your green zone and you split them up, and typical tables in a dining room are not normally 6 feet across. So the way I envision like the dining part is like you're going to have 6 or 7 tables in your dining area, and you're going to have one resident at each table. So it really is going to be, you're going to have to pick and choose who honestly gets that privilege, because you want to keep, those 6 or 7 people that dine together that first time to dine together any time that they have it. And I know sometimes residents choose not to go, and sometimes they want to go. And if they don't get to sit at the table they were at right before the lockdown happened, they may not be so happy that they don't get to go back to their same spot, that they have to sit across the room from that. So there's a lot that's going to go into it. But beyond breaking up and then, having these mini groups within the cohort so that they can have a little bit more social interaction, I don't think there's really a lot you can do other than considering like who they normally sit with. So maybe your typical table of 4 or 5 people, those are the 4 or 5 people that are together in the dining room at any given time. So that way they still have sort of their table. It's just a much bigger table now. But beyond that, I don't think there's anything additional to look at for purposes of keeping people safe and separate.
Yeah, and we did have a question, and we'll get to it at the end about what to do. Now we turned that into our staff break room. Now what the heck do we do? And so we'll answer that question at the end here, guys. So just bear with me. All right. So those are the infection prevention kind of guidance, or the quote unquote core principles that CDPH expects you to follow, and that's going to apply no matter what. And so we wanted to cover that first, because there's a lot of things in there there's a lot of areas that we can do this incorrectly. And in a second here, we're going to talk about how confusing some of this stuff is. But in terms of the general guidance, visitation should be through, can be through different means, and it's going to be based on the structure and the resident's needs, besides just a compassionate care situation. Visitors who are, and I pulled out this bullet point, and this is really important. I know people have asked, what can you do? And so visitors who are unable to adhere to core principles of COVID-19 infection prevention should not be permitted to visit and should be asked to leave. Now, what manner in which you do that, that's up to you. Like I said, I hope that's not a problem, but if through your communication with family members, you have had certain family members I used this term difficult yesterday, and Mike Wasserman took me to task for it. When I talk about difficult, I'm talking about people who have identified that they're not going to wear a mask, or they're not going to follow the infection prevention guidance. And I don't know that a lot of people seem to think that everybody is lockstep in an agreement with how we have managed this in nursing homes. And many of those folks that disagree with that are related to people that live in nursing homes, and they will be showing up at your building. Now, my hope is it's 1% of the time, but you just need to be prepared what you're going to do when they don't follow those infection prevention guidance, because it's going to be you that has the deficiency, and it's going to be you that's responsible for providing a safe environment, not only for that resident, but for the remainder of the residents in the building. So it really is going to fall on your shoulders if you let that slide. Outdoor visitations, the most important part here, and I know there is a lot of conflicting kind of language in here, and I'm going to go over where it conflicts, but I truly believe, and I think this is CMS's kind of guidance, is that all visitation should occur outside wherever practicable. And so even though as you go through the AFL, you'll see language that says you must or you shall in other areas, which seems to conflict with if you can do it outside, do it outside. We'll go over that, but I think the overarching theme and certainly the message from CMS is that the safest place to do visitation is outside. If you can do it there, that's where we're going to do it. The problem is many of you guys don't have that ability, and so you're going to have to do inside visitation. And what does that look like? So when we talk about visitation, if outdoor visitation is not possible, you're going to have to come up with some large communal indoor space, possibly depending on how many folks that you're going to need to accommodate for visitors. Maybe it's only a few, and maybe you can manage that in resident rooms, and we'll talk about how you do that in a second. But I think most folks are going to look at kind of a large communal indoor space, such as a lobby or your dining room, possibly physical therapy rooms. But look at those and set those up. Those are the spaces that you should be looking at. We've talked about airflow and air changes and making sure that those spaces are clean both before and after the visitors come into the room, and then after they leave. Those are all kind of criteria that you should be doing with the inside visitation, no matter where it is, in the room or in a large communal setting. In terms of in-room visitation, the requirement, so we've talked to CDPH, and Heidi said that they're going to be releasing guidance that kind of breaks down, the in-room visitation and the testing kind of requirements, because our county tiers don't match up with the percentages that CMS set up. So CMS sets up, 0 to 5%, 5 to 10, and 10 to and above. And our categories, even the purple category, is only 8% and above in terms of positivity rate for the county. And so for those that are in between 8 and 10%, our question was, well, where do they fall on that list? And let's not make this a moving finish line where every day we have to change this. So Heidi says they're going to create a kind of an infographic of exactly how what your facility is. And our recommendation was to stick with the percentages that CMS had said, so that it would be possible or it wouldn't require everybody in the purple counties to automatically now start testing twice a week. And it wouldn't restrict you from being able to implement visitation if you were in that 8 to kind of 10% bracket. So we'll get some clarification from CDPH on that. I'm not sure how quickly that will come out, but they did say that they were going to work on that AFL. In the interim, we're going to say in-room visitation is only for the counties in red, orange, and yellow. And let us work on CDPH on those of you in the purple counties that are in between the 8 and 10% on getting language that would allow you to operationalize this. Absence of any new cases, so you can't be under response testing. in order to do this in-room visitation. Visits for residents who share a room should be conducted in a separate indoor space, or if the roommate is not present. And if you do that, think about air changes and cleaning the room and everything like that before the resident, the roommate comes back into the room. For facilities located in counties with substantial or lower levels of community transmission, so that's the yellow or orange categories there, they may allow green zone residents indoor in-room visitation, even if they have not received 2 rounds of negative testing when you're doing the response-driven testing. And the last bullet point here says check with your local health departments, because many of these health departments are considerably more conservative than the state. So, and I'm thinking about folks like in Berkeley or Pasadena or Long Beach or Contra Costa County or Alameda County that have very, very strict, kind of visitation guidance within the county. So we're going to have to wait for the county to kind of respond to this, the CDPH AFL, and either, choose to operationalize or, kind of go by this guidance all the time or some of the time. I'm certain folks like Los Angeles County that has, such a big public health department, they will probably create their own guidance and include it in the ACDC manual. So we'll see variations for your local health departments. I would, immediately check with them to make sure that they don't take issues with specific areas of this, especially as it relates to indoor in-room visitation. All right, so some of the other considerations, you have to have adequate staffing and no staffing shortages. I think, what CDPH would say is that if you have to reduce your care staff so that you cannot meet the minimum nursing hours, then you don't have enough staff to be able to do visitation. And I would say that could be accurate, but it's not always accurate in every case. And so in cases where you're operating under a 5000A, but you may have other resources, other types of staff that are able to assist with meeting the visitation requirement. And it's something that you guys want to move forward with. Your families are really banging on the door to get in to see their family members. For those folks, we're going to have to address those on a case-by-case basis. And you're going to have to really pitch CDPH and say, look, the reason why I have 5000A is because I can't hire enough staff, but I've got these volunteers who are going to run my program, or I have some corporate staff that are going to come and help. They're not clinical staff, but they're qualified to be able to oversee the visitors and things like that. So I think you could be creative in finding a way to meet that. But for the most part, if you're under a staffing waiver and you're having a hard time meeting 3.5, 2.4, you would probably not have adequate staff in CDPH's opinion to be able to operationalize all these elements within the visitation. Patty, did we ever hear back from CDPH as if it was a hard no, or did they even comment at all about the 5000A?
Can clarify what you're asking one more time, Jason?
So if a facility has submitted a 5000A waiver for the staffing waiver, are they automatically disqualified from visitation? I know we had originally talked to them about that, and they removed that language and just changed it to no staffing shortages. But I don't know if that they had said that was an automatic disqualification from visitation.
No, we haven't received actual confirmed clarification on that. So we'll make sure we get that and get that out on the forum to everyone to make sure we get that clarified, Jason.
Yeah, that's perfect. And like I said, I think there are ways to creatively be able to meet the need if it's something that you guys really want to do, but it's going to be on a case-by-case basis.
Yeah, because Visitations, as we all know, we use, to watch and supervise visitation. There's other staff that could be trained on that. They don't have to be our staff that count in our 3.5 or our 2.4. So, we have activity staff, and we have a lot of other staff that could assist in visitations. So I'm not quite sure why that's even in there. So we'll get some clarification.
Yeah, and that was my thought. I don't want it to be an automatic disqualification, because there could be instances where you guys will have no problem doing that, but you have a problem hiring new CNAs. So, and then it goes on to talk about you need to have adequate testing. Everybody's doing testing once a week, I hope. So that should be a layup. We're already doing that, and everybody's got an approved mitigation plan, or for the most part, we have approved mitigation plans. So those last few or last couple are very easy for us to accomplish. All right, so I wanted to pull out a few of the bullet points that CDPH had referred to as to kind of, what are procedures that you could take to make sure that you're going to have a safe indoor visitation. And one of the things is obviously core principles and staff monitoring, that folks are adhering to core principles. Now, they put such as children, but the bullet point directly after that really tells you to limit the number of visitors per resident to 1 at a time. So I'm not sure how many people are just children are just going to come visit. So if you're limiting folks to 1 resident or 1 visitor at a time, and limiting the total numbers of the visitors in the facility, I think that part of it, making sure that folks adhere to the core principles is fairly easy. So many of that second bullet point is the one that's almost the most important thing for you guys, because this gives you the authority to determine what is the best kind of cadence, number, and location for these visitors. And that is 100% dependent on you. And this is an individual facility decision. The first thing we want to consider is patient safety. And that's first and foremost. And then everything else follows after that. And so can we do it safe? And what's the limit to how many residents we can do at one time? Where are they going to go? How many staff do we have to assign to facilitating that? The communication and the scheduling on the other side. That entire thing is your ability to kind of limit the risk exposure in the safest manner that you can possibly do it within your facility. So that's the kind of the building blocks of how you get this done. And I want to encourage you to make sure that this is your decision, and you may have folks that take issue with that, either family members or surveyors or something like that, and you have to frame your response in these decisions are made with resident safety being the first and foremost choice in everything we do, and everything else is secondary to that. And so that is why the rules are the way they are. When you explain that to residents or visitors about the time that's going to be allotted to them, about the, how difficult it is to come into a facility, maybe they can only come once every 2 weeks or something like that, based on the amount of time that you can dedicate to it. This is what you get to pick, but you do it in the manner that's safest for your residents. And we've talked about this, but limit movement within the facility. We don't want visitors walking around in different hallways. And they should just go to wherever the space is that they're going to have their visit, and then leave directly after that. All right. So there are a bunch of exceptions to this. And the big one is the compassionate care visitation. We know there's exceptions to healthcare workers or surveyors or ombudsmen or nursing students, folks, legal matters, disability rights advocates. All those folks have restrictions and are allowed to come into our building. They still have to follow the core principles. They still have to be screened. They still have to wear a mask. all of those things. But we wouldn't necessarily require them to call us after their visit. We would request them, say, hey, listen, if you turn positive, please let us know. But maybe you wouldn't be the first call that they would make. The more important thing with these exceptions is a compassionate care visitation. And so compassionate care visitation applies for every facility in the state. So this is not unique to facilities that are just in a certain color category. This applies to all skilled nursing facilities in the state, regardless of where your facility lies. So for permitted visitors, obviously we want to do social distancing. If a facility and visitor identify a way for personal contact during compassionate care visitation, so meaning as a part of their compassionate care, and we're going to talk about kind of the things that fall in this, but if during that compassionate care visit, the folks need to have physical contact with the resident, in that instance, they need to be screened for COVID-19 symptoms and also be routinely tested for COVID-19 at least weekly. So if you have a compassionate care situation where you have a resident family member that comes in frequently to help with portions of their care, put them into your weekly testing regimen if they're going to be in the facility that often. They need to wear a surgical face mask, not a cloth face mask while in the building, and they need to keep that on at all times. They need to be restricted to the resident's room or other location designated by you, and that's the only place they go. And they need to practice hand hygiene, obviously. And so those compassionate care visitation scenarios are for end-of-life situations. So we know that that's consistent across the board. A resident who is living with their family but has recently been admitted to your facility and they're struggling with the change in environment and lack of physical family support, that would qualify for a compassionate care visit. A resident who is grieving after a friend or family member passed away, that would qualify. A resident who needs cueing and encouragement with eating and drinking. We had that on a question with HSAG the other day. So that, yes, absolutely, that would fit under compassionate care visitation. The last one is a resident who used to talk and interact with others, is experiencing emotional distress, seldom speaking, or crying more frequently. So those folks would definitely qualify for a compassionate care visit. Now, those are defined in the AFL. There may be other situations for compassionate care if you were really interested in getting visitors for that particular resident. I would say, reach out to Patty or Deanne or myself and explain the situation. We'll see if we can work with the district office or if there are unique situations. But this is another one of those things that is subject to local health department oversight. So if they choose to say, look, I don't think that's going to happen, but it could, they could say elements of that, those scenarios that they're not comfortable with. I don't think that's the case, but you definitely want to check that. So, all right, I talked for an hour. I apologize, guys. A really dense information. I want to start with some of the questions that we saw on the HSAG webinar because I think they're general enough that you guys, many of you guys on this call, will have similar questions. And I'm going to pose this as a group. So Deanne and Patty, if you have suggestions, please jump right in, especially Deanne on this first one. I know you and I talked about this yesterday. We are using our communal space as employee break rooms when the outbreak started. Now that visitation is open, any suggestions on how we are going to accommodate employee breaks while maintaining social distancing? And Deanne had a great idea on that one that I didn't mention on the call.
Thank you, Jason. I don't know about a great idea, but just an alternate idea. I know yesterday Jason had mentioned on the call that, potentially, doing the timing thing where it is staff break room and you schedule your visits on the off time. So that way, you have to worry about air exchange, right? And you have to worry about disinfection, all those kind of interesting things. But then, so you can always do that. You just have to be very good about planning. The one other suggestion that I had just stated was that I know that unfortunately several of our facilities are down on census. And though it's never our first option to use a empty resident room in order to create either a visitation place or a staff break room, it is an option that you can take a look at if there is one. And then, you know, the thing that we always do, turn the closet into another office space. Well, this might be that situation where we look at what other spaces we have that maybe are being used much less because people are out and about in the care areas more, and maybe converting an old staff office to either the staff break room to open up that communal space, or a specific space just for visiting to occur. So a couple of options. You can be creative, of course, if you have the space outside to bring in an outside portable unit in order to either have visitors or to make that the employee break room, then there's always these options as well. So again, just getting creative with the space that you have, and maybe space that's not being used quite as much as it used to be.
Yeah, and any opportunity to, you know, if you have outside space for employee break rooms, or you know, space to have their meal breaks, you know, that's great. We're going to run out of time to do that you know, within a few months, and many of you guys are in Southern California experiencing terrible wildfire smoke as we speak. So you know, it's not always possible, but you know, if you've not thought about that, maybe, you know, consider other options for employees to have their breaks outside rather than inside. All right, on the visitation, some of our alert residents and families heard about indoor visitation, and they actually don't want outsiders to come in and are scared. Any suggestions on this, Dan?
I think that Jason stacked the cards here. I'm getting all the really tough ones. No, so this is one of those that does become a problem, because we've heard from the beginning, and in talking with advocates for, you know, residents who they want the residents' voice heard, because, you know, there have been families from the beginning and some residents from the beginning who have said, I want to be visited. I don't want to worry about, like, if I'm going to die. That's not important to me. What's important to me is my family. And then as the facility, you have to balance that with those residents. Like this question is where you have those that are like, no, I want to live. I don't want to get sick. I don't want the risk of dying. And so I'm happy to be without visitors in order to maintain that safety. And again, this comes down to how do we balance that so that we can hear our residents' voices. And the only thing that I really thought about was, again, it's so difficult because we're already cohorting people. But if you could just at least have that conversation with all of your residents to find out who is open to having visitors, even if it's maybe not for them specifically, but they're okay with having other people have family visits because of the safety you're putting in place. Or if there are individuals who, like this, are absolutely scared and don't want any visitors. And then making sure that you can possibly roommate people who are afraid and don't want visitors together in your green zone. So that way they are not, again, like these subgroups are not exposed to a roommate maybe who is accepting visitors. So taking those people that are truly not wanting it and knowing that it's not really an option for us to say no across the board, even though some of our residents want it, we could work with them to accommodate a separate room or roommating them with others who feel the same way. So that way it reduces, again, their exposure and they can feel more safe within their home environment. So that was my first thought around it. It's difficult, but then again, you know, getting the residents' voice, understanding what their fears are. Potentially these people, after hearing all of the safety measures you're putting in place, may not be so afraid and may feel a little less fearful around having those visitors. And so they might not need as much, you know, of the special handling in order to make sure that they're comfortable once you explain how you are putting protections in place.
Yeah, and I think that point of highlighting the fact that every visitor that comes into the building has the same expectations and as every healthcare worker that comes into the building. So the way that they're going to practice source control, they're going to practice hand hygiene, they're going to get screened for symptoms. All of those things are the same for a healthcare worker as it is for a visitor coming into the building. And if you explain it in that sense, I think it helps. Now, obviously the visitors are not getting tested, so we have less of an idea of the risk exposure, but in terms of the actions taken from visitors, it looks the same as it does for healthcare workers. And so if that helps to give them confidence in this is the very best that we can give them, I think that will help kind of overcome some of those objections.
Yeah, I do just want to toss in there real quick on that. Since we are open to having resident visitors in their rooms, it's going to be especially important for us to have those conversations with all of the residents in your facility, because you need to know if a roommate is fearful and then you schedule for a family to actually visit in the room, even if the curtain's pulled, we could be triggering a lot of issues for that roommate. And so we have to know that they are fearful of it, because again, we can't put them in a situation that triggers that fear. And so we would need to have that conversation while your roommate is wanting their visitor. And if you don't have, say, a separate room to do the visiting in, so that it's not in that room, then you have to be able to give that resident who's fearful other options, which would be, changing rooms or whatever it takes, so that you can maintain their needs and not have that fear come into play. So one way or the other, we're probably going to have this conversation with every resident to know exactly where they're at before those visiting comes past the front door.
Yeah, no, that's great, and shame on me for not really saying that, but yeah, absolutely, I can't agree more. So this next question, I think I kind of covered this, but this was a scenario that was presented on the HSAC call. If a resident is not isolated but can't eat his meal in the communal dining area, bedridden, requires family to come feed him since he is losing weight, is that family member allowed to come every day for feeding? Now, the compassionate care limitations, they're not in there like they are for the other things. So it's not prescriptive as to how often they can do their compassionate care visit. This would be as much as you feel that accomplishes the mission of providing the safest environment possible. So if you feel that confidently that you can provide that it's safe to have this family member come in, and I kind of covered those things that they should be expected to do. They should wear a surgical mask, not a cloth mask. They should be incorporated into testing if they're going to come in that frequently. They need to be screened daily, just like a healthcare worker. All those things need to be followed. But if you can do that, I don't know that the AFL is specific that says you can or cannot on a schedule. And this schedule is clearly important for that resident. And so I think in that instance, it would probably be allowed by CDPH. But once again, this is one of these things that I don't see local health department necessarily having take issue with this particular thing, but they may take issue with some of the elements within what's defined as compassionate care. So you want to make sure that, hey, give them this AFL and say, is this okay? I've got this person that needs to have feeding assistance 3 times a day. Can I have this person come in, and these are the conditions they're going to be expected to follow. I think most of the health departments would be fine with that. All right.
Yeah, and Jason, I'm going to jump in again, and again, just remembering the roommate, who is this person roomed with, and also the responsibility on the facility is to oversee that this person who's coming in is following those infection control, I can't remember, best practices, what are they called, Jason? We have to hold them to that standard, and if we have, say, 10 of these individual residents who have family members coming at meals, can you really adequately, with your infection preventionist and your other staff, really oversee that they're following those protocols? So you just have to be aware of that as well. So one, roommate; 2, how many, even though maybe everybody's eligible for a compassionate care visit, how many can your facility actually oversee to ensure the safety? So you want to keep that in mind.
Yeah, and that's the theme for the day. Figure out what's safest for all of your residents, and then work backwards from that in terms of operationalizing it. Because there's, this is not just, doesn't mean that you're just gonna, open up the front door and 50 people are gonna come in to visit tomorrow. That's not the way this is gonna work. So, all right. The one question was on in-room visitation. We're assuming the 6-foot distance is measured from the head of the resident. And this has to do with bedridden folks. So the question was really, can the visitor stand at the foot of the bed, and would that be appropriate social distancing? And I agree with that, and Dr. Epson agreed with that on the call. So that would be appropriate for the person to stand at the foot of the bed, but don't creep up the side of the bed, because then you're encroaching on that 6-foot distance. Whoops, sorry, I went too far here. All right. Are indoor visits allowed in the yellow zone? And what if you do not have private rooms in the yellow zone? Well, the yellow zone would be a no. So we're not doing, because you would be doing response testing if they're exposed and in the yellow zone. Now, if you're talking about new admits into the yellow zone, frankly, I wasn't clear on that. And I've asked Dr. Epson, well, okay, what about the new admits? Clearly there's a compassionate care kind of statement in there that says that this person can go into that room if they're newly admitted to a skilled nursing facility. How is that different to a newly admitted resident in the yellow zone? And I think they're probably going to err on the side of caution and say, no, yellow zone, it's just a no, because we don't know. But I haven't got that specifically yet. So once I get that clarification, I'll get it out to you guys. But I don't know the answer to that one. But if they're in the yellow zone because they've been exposed or because they have symptoms, absolutely, they should not be getting visits. But if they're newly admitted, those are the things that we don't know about. And there's a difference in the yellow zone between those that are just there to wait out 14 days and those that we think have a likelihood that they may have COVID. So, all right, how often is the blueprint updated? And I want to get to this, and I apologize, I've gone over on time, guys, but this is an important part because I heard Heidi answer that on the call, and I don't know that I agree with her answer. I believe CMS's intent is to have you check in the QSO, they pointed to having you check these data sources twice a month. Whatever day you choose to do that, the 1st and the 15th, the 5th and the 10th, every second Tuesday, whatever it is that you chose, that seems to be consistent with what CMS wants, is to pick an arbitrary date twice in a month. You're going to check and reincorporate that. Now, on the call yesterday, Heidi said, check it every day. Well, that's great. You can check it every day, but in order for you to kind of logistically operationalize visiting and scheduling and all that stuff, you can't just change that at a drop of a hat. And especially if you have to pay staff to show up to man these kind of responsibilities, and then tomorrow you're out of that category, so you can no longer have a visitation, or you have to change the type of visitation you do based on that color category. That's not feasible. And so I think my recommendation to you is to continue to use the dates that you had originally picked and just use the data source as the California source. That's what I would do. That's what I'm going to ask Heidi if we can clarify on the next AFL. I think that's consistent with the CMS QSO of checking it twice a month. And then we're just updating the data source we use to gather that information.
All and right, on top of that, Jason, just real quick to say, make sure again, documenting. So documenting which days you're going to check and documenting what it was when you checked. So that way you have consistent follow-up. So if anyone questions why you haven't made some kind of a change or another to your visiting or other processes, that you have the documentation showing when it was that you checked and that that's your system and that you're following it on a consistent basis, and that will help with those responses.
Yeah, that's perfect. And what there's obviously a number of things that are brewing this week or occurring this week. We just didn't have a chance to get to them, but the antigen testing, if you're going to use the POC antigen testing devices, you're no longer going to report the test results to CalReady. You're going to report those results to NHSN. You need a SAMS level 3 security to be able to input that stuff. So if you don't have that, you're going to have to go through the process to get the SAMS level 3 first. And then you'll be able to report directly to NHSN. And once you start doing that, you'll no longer have to do ReadyNet. And next week, we'll cover the kind of the process to do that. Los Angeles Department of Public Health issued a health alert on post 90-day positivity. You no longer have to retest those folks. That's just Los Angeles County. It's nowhere else yet. Please see the LA HON and the CAF e-alert that we sent out. There's an AFL that came out today that talks about each one of the surveyors is going to wear a 2020, 2021 sticker to let you know that they've had the flu shot, and that's an AFL that came out today. And then I wanted to include the handout that we included last week, as well as a link to the sign up for the pharmacy partnership program. If you've not get signed up, you've got until November 6th to get signed up to be a part of the vaccine program. If you don't get involved in this tier 1A, the chances are you're probably going to get pushed back to tier B. So it's important that you get signed up as quickly as possible. All right, I want to say thank you to Patty and Deanne. I'm super sorry, guys, for going over and taking some of your time on a Friday. Hopefully you have a great Halloween, a great weekend. Thank you, Jamie. Thank you, Deanne. Thank you, Patty. Thanks to all you guys. Have a great weekend.